Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Stacie Macdonald. Dr. Macdonald received her Bachelor of Arts degree from Binghamton University in New York. Dr. Macdonald attended medical school at St. George's University School of Medicine. She completed her residency at Robert Wood Johnson University of Medicine and Dentistry of New Jersey Cooper Hospital. She is board certified with the American Board of Obstetrics and Gynecology. Dr. Macdonald's special interests include general and high-risk obstetrics, minimally invasive laparoscopic surgery, and pelvic organ prolapse and bladder control. Dr. Macdonald currently practices medicine with the Washington Township Medical Foundation in Fremont.
Good afternoon and welcome. I'd like to talk today about minimally invasive options in gynecology. So the landscape of gynecologic therapies and surgeries is continually evolving, with an emphasis on minimally invasive options. As new surgical and non-surgical options emerge, they enhance our ability to individualize treatment plans for our patients. The focus of my presentation will be on the types of minimally invasive procedures and surgeries that we perform. I will discuss what medical conditions we are using these to diagnose and/or treat, including family planning, surgical and non-surgical options that are the most reliable. I just wanted to take a moment to describe the anatomy that I'll be discussing. We have the ovaries, fallopian tubes, uterus, cervix, and vagina. As for the ovaries, think of these as the production center for the hormones that are involved in a woman's monthly cycle. They release the egg, which travels through the fallopian tube into the uterus, where if it's been fertilized, it can implant so a baby can grow. If it has not been fertilized, this balloon-shaped organ, the uterus, the lining, will actually shed every month, and that'll give us our monthly periods. When you look at the cervix, think of that like the gatekeeper. It's keeping things out, as well as holding things in when we're pregnant, keeping the baby inside. And the vagina is a tube from the outside to the inside. This is actually a photo of an actual uterus taken during a laparoscopic surgery, and you can see the ovaries, fallopian tubes, and the uterus itself. So a current focal point for most surgeries is to proceed with a minimally invasive approach, and that goes across all surgeries nowadays. This means in gynecology, we're attempting to use an approach which avoids a large abdominal incision. The benefits for this are that it provides a faster recovery, less pain, less blood loss, decreased scar tissue formation, and better cosmetic results. So hysteroscopy is one of our common techniques. This is when we use a small camera to see inside of the uterus, and we're able to do this using fluid within the uterine cavity. The purpose is to discover the causes of abnormal bleeding, treat heavy bleeding, remove small growths, place implants for the purpose of sterilization, or treat scar tissue. This photo demonstrates the small camera, which is attached to a video monitor, and the camera goes through the cervix into the uterus where we instill some fluid. Note there are no incisions during this procedure. We're only working within the uterus itself. Patients go home after the procedure, and recovery is typically 1 to 2 days, and usually with minimal discomfort. Frequently, the only restriction after this procedure is to avoid putting anything in the vagina for approximately 2 weeks to decrease the risk of infection. Laparoscopy is using a small camera to see the inside of the abdomen or pelvis. Gas is used to distend the cavity, and thin instruments are inserted through small incisions in order to operate. The uses in gynecology include removal of ovarian cysts, ovaries, fallopian tubes, the uterus itself, identification and treatment of problems causing pain, sterilization, or cancer staging procedures. So this shows laparoscopic surgery, where you can see the camera going into the abdomen. Several other smaller incisions are made in order to operate. Depending on the procedure that's performed, patients will frequently go home right after the surgery, and recovery time is often only 1 to 2 weeks, but can be longer for some of the more extensive surgeries. What's exciting about laparoscopic surgery as opposed to traditional abdominal surgeries is if you look at the size of these incisions, they're frequently 1 centimeter or less. So moving on to family planning. The only form of contraception that is 100% successful in preventing pregnancy is abstinence, but we have some pretty good alternatives. So long-acting reversible contraception options, these are things that are placed and removed in the office, including intrauterine devices, as well as another implant called Nexplanon. Sterilization is a permanent procedure, and this can be performed either laparoscopically or hysteroscopically. So the Mirena intrauterine device is a reversible form of contraception. It releases a progesterone called levonorgestrel over a 5-year time period. What this hormone does, it alters the cervical mucus by thickening it, which provides a barrier to the sperm from getting in. It also inhibits sperm movement once inside, and it thins the lining of the uterus. This last point is actually very exciting for us as gynecologists. What we will frequently see is that 1 out of 5 women will no longer have a period when they use the Mirena IUD. What we will also see is that about 40% of women with longer use will stop having periods. These will return when the device is removed. So as the lining becomes thinner, there is a decrease in uterine cramping because the uterus doesn't need to expel as much fluid and blood. So we find less discomfort. So what makes this so exciting is we can actually also use this to treat women who have heavy or crampy periods. This is a picture of the Mirena IUD within the uterus itself. What we also found, or what the company found, was that some women were having the Mirena IUD removed because they were concerned they weren't getting their periods. So the company came out with a lower dose of the same brand. So the Skyla intrauterine device releases the same hormone, the levonorgestrel, over a period of 3 years, but it is a lower dose. This reversible option still alters the cervical mucus, thickening it, thins the uterine lining, and inhibits sperm movement. Periods are lighter with this device, but we find frequently much less percentages of women will stop getting their periods with it. And this is a picture of, again, the IUD within the uterus. We do have an option that is non-hormonal of intrauterine devices. This is called the Paragard IUD. It is a copper IUD, no hormones in it, and it's effective for 10 years, so it's the longest acting form of birth control. It's immediately reversible, again, removed in the office for most patients. The copper in the intrauterine device interferes with the sperm movement, egg fertilization, and may prevent implantation. And this is a picture of the Paragard IUD. The second type of long-acting reversible contraception is something called Nexplanon. This is a small rod which is inserted into the arm. It also releases a progesterone. It's a different one. It's called etonorgestrel. This is slowly released over a 3-year duration. It suppresses ovulation, which is release of the egg, and it also thickens the cervical mucus. As you can see, this is a small rod where it goes into the arm. It's about 4 centimeters in length. Sterilization is a permanent operation to stop a woman from being able to get pregnant. Fallopian tubes can be burned, cut, tied, have bands or clips placed on them, or implants placed within them. So there are multiple ways in which we can accomplish this. Effectively, these methods will all seal the tubes closed, which will prevent the sperm from meeting the egg. As far as the egg, it does get reabsorbed into the body. We can accomplish sterilization either hysteroscopically or laparoscopically, occluding the tubes with either Escher implants when we perform this hysteroscopically, or occluding the tubes with the previously mentioned forms laparoscopically, or lastly, we can actually remove the fallopian tubes. So this shows a small camera into the uterus and threading the Escher implant into the fallopian tube. Over time, this will cause scarring and the tube will be closed. It takes approximately 3 months for complete blockage to occur, during which time it is very important to use backup form of birth control because you still can get pregnant until the tubes are blocked. After 3 months, we recommend having a special X-ray procedure in order to determine that they are truly closed. Laparoscopic sterilization. This is a procedure, it's the same day, so patients go home within the same day. Small camera placed into the abdomen in order to visualize the tubes. Bands can be placed on them or clips. Again, they can be cut and tied or they can be burned. All of these are going to effectively seal the tubes closed. Recovery time after the procedure is usually 1 to 2 weeks, and it is immediately effective. It's important to note that this will not affect your menstrual cycles when we perform sterilization. If you've been using a hormonal form of birth control, such as the Mirena IUD or a birth control pill, you may notice that your periods become heavier or have more cramping afterwards. This is a result of stopping the medications, not of the surgery. So remember, sterilization procedures are recommended only if your family is complete. So what are we treating? We can address a number of disorders with minimally invasive techniques, and now I'd like to briefly describe some of these disorders. So pelvic pain can be caused by a number of different disorders. They can be caused by musculoskeletal problems, digestive, urinary tract problems, infections. We can also see things such as endometriosis, fibroids, or ovarian cysts, and at times there is no identifiable cause. When we're unable to achieve satisfactory results with medications or a diagnosis is unclear, we'll take a look laparoscopically. Adenomyosis occurs when cells from the lining of the uterus grow within the muscular wall of the uterus. This is a benign condition, however, it can cause significantly painful periods. At times it's been mistaken for fibroids, however, this is much less common than fibroids. This is a diagnosis that we may suspect, but is difficult to identify on imaging studies and is usually confirmed after removal of the uterus or what is thought to be a fibroid. Endometriosis occurs when tissue from the lining of the uterus grows outside of the uterus in other areas of the abdomen or pelvis. The biochemicals which are released by the endometriosis irritate the surrounding tissues, causing pain, and it may also cause scar tissue and/or infertility. This is a complex disorder where findings do not always correlate with the severity of the disease that's found. In other words, there are times when we take a look laparoscopically and we will see only a very small amount of endometriosis and the patient has an extraordinary amount of discomfort. Likewise, we can sometimes take a look and find women who have a tremendous amount of scar tissue from endometriosis and almost no discomfort at all. Ovarian cysts occur when a collection of fluid happens within the ovary. Most of these are not cancerous. Some of these women don't have any symptoms at all, and they're what we call an incidental finding. Either an imaging study was done for something else and the cyst is discovered, or during a routine pelvic exam, we find an ovarian cyst. The range of symptoms that people present with ovarian cysts can be dull all the way to sharp pain, and the treatment depends on the cyst size and type, as well as the patient's age and symptoms. So here you can see an ovarian cyst being approached laparoscopically. If it's determined that we need to remove the ovarian cyst, in many cases we can actually remove the cyst itself or drain it and leave the normal ovarian tissue to continue functioning. Abnormal uterine bleeding is a term that we use to describe bleeding that either occurs too frequently or excessively. We look at the quantity. Is a patient soaking pads or tampons hourly? Is she having accidents or passing large clots? And the frequency, is it occurring for longer than 7 days? Are her cycles less than 24 days? Or is there bleeding between cycles? Essentially, is there any bleeding that's interfering with her life? And is there any bleeding after menopause? One of the structural causes of abnormal uterine bleeding is something called a uterine polyp. These are actually common benign growths that occur on the uterine lining. As they grow, they become fragile and can shed or bleed irregularly. These may impact fertility and may be a risk for miscarriage. Again, they are usually benign, however, we usually do recommend removal when they're found. This is a hysteroscopic view of the uterus showing a normal cavity. This finger-like projection is a large uterine polyp, and we are able to remove this hysteroscopically, again, no incisions. This is a submucosal fibroid right here, and fibroids are something I'll be talking about a little bit later. Endometrial ablation is a minimally invasive option for treating abnormal uterine bleeding. There are various methods which we can use to perform this using either heat, cold, or radiofrequency to destroy the lining of the uterus. The goal is to reduce menstrual flow to light or normal levels. Some women have the side effect where they stop having periods after the treatment. Again, it's a non-hormonal treatment for abnormal uterine bleeding, but it is not a form of contraception or birth control. I currently use the hydrothermal endometrial ablation technique, whereby I'm able to visualize the whole process. So a hysteroscope is inserted into the uterus, which is then bathed with very, very hot water in order to accomplish the thinning out of the lining. Afterwards, patients typically have cramping for a day or two and watery discharge for a few weeks. So due to the frequency with which we see women with fibroids, I'd like to spend a few extra minutes discussing them. These are benign tumors that arise in the muscle layer of the uterus. These are very, very common. By age 50, there are studies which suggest that 70 to 80% of women have fibroids. The causes of their growth are not fully understood. There are risk factors that we see can be associated with them, but not causative factors. We believe that genetics plays a part. It appears that women who have no pregnancies have a higher risk, as well as alcohol use, weight, and diet can all seem to be contributing factors. So as we look again at our uterus, we now see these white balls within it, and that's actually, fibroids do look like white balls. They can occur on the outside of the uterus, pushing into the cavity of the uterus, or just within the wall itself. And the symptoms can be related to where they are. So again, fibroids, as far as the symptoms that we hear from women, the most common is no symptoms at all. We can then see some abnormal bleeding, pelvic pressure, painful menses, pain with intercourse, fullness, a feeling of a mass, urinary frequency, or constipation, depending on where the fibroid is pushing on. So again, when we look at treatment options for fibroids, if there are no symptoms, there is no treatment needed. Otherwise, we can try medications. We can perform a myomectomy, which is removal of the fibroids themselves, a uterine fibroid embolization, which is where the fibroids are attempted to be shrunk, and there's some exciting research going on other techniques for this right now, or the definitive treatment is a hysterectomy. So when we talk about a myomectomy, the purpose of removing the fibroids but leaving the uterus is to preserve fertility. Depending on the size, location, and number of fibroids would depend on the type of approach that we would recommend, whether it be laparoscopically, hysteroscopically, or abdominally. Unfortunately, the younger a woman is when this procedure is done, the longer she has for potential return of symptoms. And there is approximately a 15 to 20% risk that symptoms will not be improved and or they will recur requiring further surgery. So again, we usually only recommend this procedure for women who are desiring of future childbearing. Unfortunately, many women who have significant symptoms from fibroids will commonly either have large fibroids or multiple fibroids, and this does tend to limit our options for an abdominal approach for their removal. A uterine artery embolization is placement of small particles in the blood vessels that supply the uterus through a small catheter by an interventional radiologist. There is also a risk of symptom return with this and reoperation of approximately 20%, and with this procedure there's a small risk of premature ovarian failure. A hysterectomy, again, is the definitive treatment. So this just shows how a uterine artery embolization is performed. A catheter is placed into the groin area and it's threaded through to the artery supplying the fibroid, in which the particles are placed in an attempt to decrease that blood flow and shrink the fibroid, thus reducing symptoms. So when we talk about a hysterectomy or removal of the uterus, we have three approaches that we can try. We can do the traditional abdominal approach, a vaginal approach, or a laparoscopic approach. We consider it a total hysterectomy when the cervix is removed with the uterus, with or without the removal of the ovaries and fallopian tubes. And this brings us to the reason I believe it's important for women to be aware of all of these minimally invasive options. There are over 500,000 hysterectomies performed annually in the United States. These options can help lower the number of hysterectomies done, as well as provide less invasive approaches to removal of the uterus. So there are studies that show that as of 2009, 56% of all hysterectomies were still being performed abdominally. When we compare these approaches, the abdominal approach requires a vertical or horizontal incision on the lower abdomen. Frequently, it will be about 4 inches. Usually, it's a 2 to 3 day stay in the hospital and a longer recovery period of 6 to 8 weeks. Looking at a vaginal hysterectomy, there are no scars on the abdomen. It is a much less painful procedure, a much shorter hospital stay, usually discharge home within 24 hours, and a shorter recovery time with return to normal activities within about 3 to 4 weeks. And again, comparing laparoscopic hysterectomy, we have superior visibility, much smaller incisions, a much less painful procedure, a shorter stay, again with patients typically going home within 24 hours, and a shorter recovery time and return to normal activities, usually within 3 to 4 weeks. This is just showing a laparoscopic surgery as there's an approach to the uterus with the small instruments in order to detach and remove the structures. I wanted to just say a quick note on robotic surgery. For a robotic hysterectomy, this is actually a form of laparoscopic surgery using a robot. There are some benefits to the surgeon. Most of them are ergonomic in helping our hands. However, when we compare the outcomes of a robotic laparoscopic surgery to a laparoscopic surgery without the robot, we find the outcomes are similar. Therefore, the robotic surgery is a more costly procedure to do, and it does take significantly longer to perform. Because it does have some advantages, this is a benefit for certain surgeons to use, but it's best used for unusual or more complex cases.
I'd like to thank Dr. Stacie Macdonald for being here today and presenting all the valuable information. Thank you.
Thanks.